بسم الله الرحمن الرحيم. أعتقد إن احنا نبتدي. آم، May I introduce دكتورة شيرين أبو النجا. She's a consultant ophthalmologist في كايرو University. آه، She's specialized in uveitis and inflammatory eye disease. ممكن يا دكتورة تبتدي إن شاء الله البرزنتيشن بتاعتك culprit you must suspect.
ميرسي جدا على انكم يعني you're having me join. و I have to say ان انا فعلا استمتعت جدا بالميتينجز اللي فاتت قوي قوي قوي. ونبدأ بقى ان شاء الله. هو the culprit you must suspect. هو يعني ايه culprit؟ what are other words for culprit؟ culprit يعني criminal او offender، the crook أو the sinner المجرم. ف who do we have to suspect? I had a patient. She came to me. She was 66 years old. She had a history of carcinoma of the breast. She had received surgery with chemotherapy. At presentation, she was free. She had no history of diabetes or hypertension and no relevant family history. She herself was very distressed and very irritable, given that she had a very long history. So elsewhere, she had had a left phacovetrectomy plus posterior chamber IOL. She had an intravitreal triamcinolone injection 18 months ago, as the vitreous was noted as being turbid, and uveitis was suspected at that time. She had an IOP rise and persistent vitreous turbidity along with an AC reaction. And she was referred to a uveitis specialist, where she received topical and systemic treatment for bilateral recurrent panuveitis. So the classic that she was given was systemic prednisolone, 20 milligrams per day, azathioprine, 50 milligrams every 12 hours, and the topical Predfort, Cozopt, Alphagan, and Cyclo. In addition, she had a right cataract. So I had initially كنت عاملة البرزنتيشن دي كان فيها زي بول، وقعدت أفكر should I leave it or should I remove it, and I decided to leave it for us to consider our thinking process and the approach of cases that we see. So the question or the initial idea was, what could the differential diagnosis be given the history of this patient with a bilateral recurrent panuveitis? So things that come to mind could be sarcoidosis, TB, VKH, Behçet, viral, or others. Now, taking the history and what the treatment that she received, the patient unfortunately showed no improvement. So, given that we have that now, would we change our initial differential diagnosis? And here the options would be, yes, we could change it, مثلا from sarcoidosis to whichever you want to choose, to viral or whatever. Or would you change it to another entity completely not in this previous list? Or would you remain as you were at the diagnosis that you had picked? Now, we have a poor response. So what is wrong? The previous investigations of the patient and the systemic uveitis screen was done. Quantiferone was negative, toxo CMV, HSV, and rubella were negative. ESR and CRP were normal. And imaging in April was done, 2019. She had an ultrasound with showing diffuse choroidal thickening, dense vitritis, and the comment on the vitrectomized eye that she had amorphous echoes, maybe injected material or silicone oil remnant. So silicone oil remnant as an answer to the report طبعا doesn't really work because the patient was not siliconized. Her OCT showed just an epimacular gliosis, and otherwise she had a normal macular study and a normal optic nerve head study. Now, next question. What would you do? Would you continue with the treatment? It's just a matter of time. She didn't have enough time and she will improve. She will respond. Or change to systemic steroids in a stronger dose, for example. Or would you totally change the systemic and local antiviral therapy? Would you consider TB? and move to anti-tuberculous therapy? Or will you perform the cataract in the other eye and see what happens? Or none of the above? So actually what happened is that the patient had the phaco done elsewhere, and she had the IOL implanted. Of course, she was still dissatisfied. She still had the persistent ocular inflammation. So at this point, she was very frustrated, very flustered, and she traveled abroad to get a fourth opinion, and that was at Barakeh, where they did a therapeutic and diagnostic pars-plana vitrectomy for PCR, culture, and cytology for a recurrent pan-uveitis unresponsive to treatment. Now, the screening that was done there included the PCR studies, which were all basically negative. Herpes, viral, everything was negative. The microbiology was negative. Serology was negative. All of this was negative. And eventually, the cytology showed us this. There was a B lymphoproliferative process of CD20 positive cells. Brain nuclear magnetic resonance was done, and a consultation with the oncohematology was done, as well as this patient turned out to be an intraocular lymphoma. Now, since the brain was normal, the diagnosis here was a primary intraocular B-cell lymphoma. So the findings at her presentation, when she came to me on the 28th, 7th, she came with the diagnosis. We already know the diagnosis at this point. Or she came to me already with the diagnosis, and basically she needed the treatment process. Her visual acuity, the best visual acuity was 0.8 in the right eye, 0.6 in the left. She had pigmented KPs, she had flare +2, cells +3. The iris and the pupil were okay. She was pseudophakic. And in the left eye, the IOP was 27 on COSOP. She was vitrectomized in that eye and still had an inflammation with a vitritis of +3. And the other eye was also vitrectomized, as we had agreed. The one that was vitrectomized eventually in Spain was the left one. And well, the right eye showed no lesions. In the left eye, I had seen a white retinal lesion at a blood vessel bifurcation at 6 o'clock. Otherwise, everything else was normal. I had asked for an FFA and a FAF study, and I had specified that I needed images of that lesion. However, unfortunately, something that happens frequently in Egypt, and we need to keep reminding our colleagues, and we need to keep reminding people that the periphery is important. And for us as uveitic or as uveitis specialists, we need to see the retinal periphery. So unfortunately, I had no feedback on that lesion. However, everything else seemed normal. The systemic screen, I continued as well, and everything was free. She didn't have any systemic involvement. Everything was okay. And now we were left at the treatment. The local therapy was with intravitreal methotrexate, 0.4 milligram per 0.1 mil. The first month, you give 2 injections a week. The second month, it's 1 injection a week. And the third till the 12th month, you go for 1 injection per month. It's a very tough regimen for patient and for us. And given that it's 2 eyes and you will not inject both eyes at the same setting, this is quite a hassle for the patient. The potential side effects of the intravitreal methotrexate are transient keratopathy, conjunctival hyperemia, and a macular edema, which my patient actually had with the first injection. I'll come to that in a point. Second thing we need to tackle is the systemic therapy, or the systemic workup, or the look at the disease. Since IOLs, or the intraocular lymphomas, are actually a subset of CNS lymphomas, and 60 to 80% of intraocular lymphoma patients actually do have a CNS involvement. And if they don't have it at the time, around 56 to 90% of these patients who don't have this will develop a CNS manifestation later on in their life. Therefore, at this point, if they do have one systemic treatment, should be considered or can be considered and is debated in literature. However, what is mandatory is the regular CNS imaging and consultations with the hemo-oncologist and the neurologist to keep check of any progression or any CNS disease. So now the procedure, as I had already said, I aimed at lowering the IOP 1 week prior to injection, and then she was given the first injection, and she gave a little bit of this toxic reaction, a conjunctival hyperemia, a mild keratopathy. And at that point, I had found in the literature that you can add folic acid, 1 gram per day, and this actually helped. When we injected the second eye, we did not have this problem, and the reaction had resolved in the other eye as well. So again, I told you that this is a very big hassle for the patient, and unfortunately she had a very long traveling distance, so we managed to arrange. She was lost to all of follow-up from me, but I had prior to that already enforced that she needs to follow this treatment near to her so that it would be convenient and that she must abide by it. So once again, who was the culprit? At this point, masquerade uveitis, for example, the B-cell lymphoma, which we have to consider in these patients coming at these vulnerable age groups. Thank you very much.
Thank you, Dr. Sherein, على a very nice presentation, very nice case. Um, may I ask, how old was your patient?
I think I said she was 68 when she came, or 66.
Okay, so she's the age of lymphoma. But you said
Yes.
that she was كان عندها cancer breast كمان?
Yes, هي interestingly ان هي السيستميك او الهيستوري بتاعها ان هي she had already previous cancers.
اوكي.
Uh,
لكن ما كانتش بتاخد drugs زي check inhibitors, checkpoint
لا
inhibitors وحاجات زي
خالص. No
اه
no
اوكي.
no no خالص
اوكي.
خالص، وكانت القصة دي already منتهية بقى لها فترة.
اوكي. لان it is now يعني surfacing ده as a cause of uveitis.
Yes. Mm.
uh, very interesting.
Um, I could add حاجة very interesting، لأن أنا لسه شايفة حالة من كام شهر. الحالة دي كانت متشافة من colleagues elsewhere، ولما بصيت على الفايل هي she was seen in August, and in August she had dense vitreous opacities، وهي عيانة high myope glaucomatous، وكمان عندها AMD، وكانت وصلت بالجلوكوما بتاعتها in the vision was around 0.25. ف one presentation later كانوا the colleagues had reported ان ال visualization بتاعت الفندس is a little bit turbid، بس nobody noticed where the slight drop of vision اللي كان حاصل ساعتها غالبا was relayed لل further comorbidities اللي موجودة في العين. When I saw her in August with the age group كمان, she's around 70s. I saw the patient and I suggested يا جماعة this could be a lymphoma, and the vitrectomy was done وهي فعلا طلعت lymphoma. And this is another trick مع intraocular lymphomas. They are masqueraders, sometimes very subtle, and if you have other comorbidities كمان it makes the diagnosis even further difficult. وهم they are this subtle in it is يعني mentioned in the literature in the first diagnosis can be delayed from 6 months to 40 months from the first sign onset.
That's interesting. طيب انت حضرتك الحالة ديت عالجتيها ازاي؟
برضو أخذت intravitreal لأن هي طلعت systemically free totally، يعني she had the full screen and she received the methotrexate intravitreal، she's back up to a vision of 0.15 at this moment.
Yeah, very interesting. شكرا جزيلا. أكيد في ناس تانية عاوزة تسأل أسئلة للدكتورة شيرين.
شكرا جزيلا دكتور شيرين. بعد اذن حضرتك دكتور محمد، عندي سؤال من فضل حضرتك كومنت.
اتفضلي.
Thank you, Dr. Sherein. Really very interesting, and thank you for raising this important issue. I have, in fact, a comment and a question for you.
Of course.
Yeah, there is a very important clinical sign, Dr. Sherein. Of course, you are aware of. If you have massive vitritis or dense vitritis like this, and not associated with macular edema, this raises the possibility of lymphoma, because we used to have vitritis and we have this kind of vitritis. We should have macular edema if we don't have. So this make us suspect lymphoma. The second issue, the problem here in Egypt, I think, and in most of the countries that they don't have specialized labs, you can get a good sample, but the lab or the pathology report is not sufficient, I think, and we have cases like this. We need specialized labs and specialized pathologists to help you to establish the diagnosis. The third part is a question for you, Dr. Sherein. The issue of lymphoma is very confusing. As you know, we have Hodgkin's lymphoma and non-Hodgkin's lymphoma. We have primary and secondary intraocular lymphoma. We have choroidal and vitreoretinal lymphoma. So, can you help us how to differentiate? For example, if you have a choroidal lymphoma, this could be metastasis secondary to systemic lymphoma, for example, because of the blood flow to the choroid. And the vitreoretinal lymphoma, is it associated mostly with intracranial lymphoma? So the issue is a little bit confusing. Can you just give us a hint how
Sure.
to clinically at least suspect any type?
Type. Mainly, the subset that we meet in intraocular lymphoma are B-cell lymphomas. Very rarely they are T-cell lymphomas. Where they are B-cell lymphomas of the non-Hodgkin type, where they may embed anywhere in the eye, either the choroid or the retina. And as you said, the biopsy is sometimes difficult. If we usually take a vitreous biopsy. However, the actual seat of the B cells is in the retina. That's why if we're lucky, the cells infiltrate the vitreous from the retina. If we're not lucky, sometimes, and we have a very high suspicion, we are forced to take a retinal biopsy. On the other hand, yes, the main seat, followed by the choroidal, if I remember correctly. But the vitreoretinal is the main seat of the intraocular lymphomas. And we will have to do a follow-up, or we'll have to do a screening either ways in all cases. If we see anything in the eye, we have to exclude the CNS. An MRI is mandatory. And then the further screening of the systems. If we have a lymphoma that we know of elsewhere and we suspect that that is a metastasis, then yes, of course, we need to search for the other sites in the body.
Excellent, excellent, Dr. Sherein. Thank you very much.
I would like to add another tip. One of the things that also differentiate intraocular lymphomas from a non-infectious uveitis is an IL-6 to IL-10 titr. The IL-6 is raised in the non-infectious uveitis, whereas IL-10 is raised, it's higher with the lymphoma. So the IL-6 to IL-10 can help us as well as an indicator.
Okay, good. This is in the vitreous sample, Dr. Sherein, right?
Yes,
Yeah,
yes, in the
yeah.
vitreous or even the aqueous sample.
On the aqueous sample. Okay, excellent,
Both.
excellent. But I wish we have labs that can do this. This will be very helpful.
I think if we do tell them that we need this, but our problem is that our samples are always very precious.
Yeah,
However, a vitreous sample from a biopsy, يعني هي the thing is with the first eye that was vitrectomized was a sad loss. This vitreous, when it's very turbid, we don't have much of the culture of taking and sending for cytology and sending for pathology. If we had this much more common, what you take, you need to sample, we wouldn't have a big problem, because the first eye, the diagnosis was lost because she was just vitrectomized.
yes.
Simply as. The second eye that we had, the second eye, and that it was infiltrated in the first case that I mentioned, we were lucky because we could find the culprit. It's part of the how we are used to approaching our cases, and that we need to raise فكرة ان انا اي حاجة بشيلها المفروض انها تتحلل، وكمان ان احنا نعرف ناخدها ازاي، لان السامبلينج بتاع الليمفوما ليها طريقة معينة، وان احنا ناخد جزء من السامبل ونسبريد على السلايد فتبقى سيتولوجي على طول. when we're in contact مع الباثولوجيست this is the best way of handling the sample على طول. one to one، حضرتك عايز ايه ازاي هجيبها لك، خلاص done that way.
Perfect.
طيب ممتاز. يعني I think we need to move لدكتور سمير. تهيألي كده ده السكند
ايوه.
presentation هتتكلم على يعني controversies in TB diagnosis
Yeah.
of ocular TB.
Okay.
دكتور سمير شوقي طبعا is the president of our group Egyptian UveitisbStudy Group، وهو طبعا معروف للجميع وعنده كذا study around around uveitis sarcoidosis و TB in particular. هيكلم لنا النهارده عن الدايجنوز of ocular tuberculosis.
السلام عليكم ورحمة الله. شكرا
الله عليك.
جزيلا دكتور محمد العزيز على المقدمة الجميلة، وشكرا جزيلا طبعا دكتورة مي على المجهود الرائع، الدكتورة شيرين على المحاضرة القوية ما شاء الله تبارك الله يعني. شكرا دكتورة مي على إتاحة الفرصة ليا النهاردة إن أنا أتكلم على ال diagnosis of ocular tuberculosis. She's not working. Yeah. So, tuberculosis is one of the top 10 causes of death in the world, and it is a very important cause of uveitis, in fact. But extrapulmonary TB and ocular TB is one of the manifestations of extrapulmonary TB, accounts for up to 20% of cases. So we have to consider extrapulmonary cases and not to think only of the pulmonary TB. We have several problems with ocular TB because the exact prevalence is not known in Egypt or worldwide, and you can see the variation here in the tubercular uveitis affects from 0.2 to 10% of cases of uveitis. But please pay attention to this very important piece of information. 92% of patients with ocular TB show no concomitant pulmonary TB. Why I would like you to stress on this point, because in most of the recent diagnostic criteria, they emphasize on the presence of chest X-ray or CT findings or evidence of either active or healed pulmonary TB. Again, 92% of patients with ocular TB show no concomitant pulmonary TB. We have several problems in the diagnosis and the management of ocular TB, and this is for a reason, because of lack of evidence of coexisting active pulmonary TB, as we mentioned, and all uveitis specialists in Egypt and even in the world have difficulties in convincing pulmonologists to start antitubercular medication for ocular inflammation alone. The second possible cause of this difficulty is the variable clinical manifestations in the eye. As we know, TB is a great mimicker, like a case of syphilis and sarcoidosis. We have granulomatous and non-granulomatous, bilateral, unilateral, anterior. So this makes the diagnosis of ocular TB is difficult. The third cause is the absence of global consensus. As we know, the incidence and the endemicity of TB in Egypt is not like India, not like Europe, not like USA. So there is no global consensus for initiating antitubercular medication. Also, differences in regional practices, and there is no internationally accepted standardized protocol. Of course, the gold standard for the diagnosis of ocular TB is the histopathological confirmation and the detection of Mycobacterium tuberculosis from the ocular tissues or fluids. And as just Dr. Sherein mentioned, our samples are very precious. The problems with ocular TB, we have usually small size for ocular tissue biopsy, and the ocular TB is a paucibacillary disease. This means that very few number of Mycobacterium tuberculosis organism can cause the disease, so it can be easily missed in the ocular samples. The diagnosis of ocular TB, of course, depends on the local epidemiological factors and ocular phenotypes and the immunological tests. For example, if you have a case like this with anterior granulomatous uveitis, and you can see here the maton fat KPs, and this patient comes with a positive quantiferon test. So are you going to treat this patient? We have several dilemmas here and the questions to answer. Is this eye problem due to active tuberculosis? If it is due TB, is it due to direct invasion and infection of the eye, or is it a hypersensitivity reaction to, um, to Mycobacterium TB? Or it is both active infection and hypersensitivity reaction. And the treatment is different. Of course, if it is an active disease due to active replication of the organism, you have to give antitubercular medication. If it is a hypersensitivity reaction, you should give steroids. That's why the CUTS study group was established. It was a survey-based clinical study to address the knowledge gaps in the area of antitubercular medication and initiating antitubercular treatment for patients with presumed ocular TB. It was a consensus-based algorithm. It included 81 uveitis experts from the world, and I participated representing this part. Simply, I will just try to simplify the findings of the CUTS. And they divided the uveitis anatomically. For tubercular anterior uveitis, you have to have positive radiology, either CT chest or chest X-ray, in order to establish or to start the treatment with antitubercular medication. As you can see here in this table, in all scenarios, you should have one immunological test, either tuberculin skin test or the quantiferon, in addition to a positive radiology. So you can see here radiology must be positive in all scenarios. So if you don't have a positive CT chest or chest X-ray finding of either active or healed TB, you are not justified to start antitubercular medication for a case of presumed tubercular anterior uveitis. The same also applies for tubercular intermediate uveitis. As you can see from the table under the radiology here, you have to have positive evidence of tubercular infection with either tuberculin test or quantiferon test. But the condition here in the choroid, in the posterior uveitis, the same for focal and the multifocal choroiditis. The only exception is serpiginous-like choroiditis. You can give treatment based on either tuberculin or IGRA alone, and you don't have to have a positive chest X-ray or CT chest. And this is the algorithm. You can find it in the COTS paper. But is it applicable? As we mentioned before, so in the COTS study, they emphasize on the presence of positive imaging in the chest in order to start antitubercular medication. But as we mentioned, 60% of patients with extrapulmonary TB in general have no evidence of pulmonary TB. More, 92% of patients with ocular TB show no concomitant pulmonary TB. So you have 90% of cases that present to your clinic with ocular TB will have no chest X-ray findings of TB. So how come I put CT chest as an important or a must criterion for starting antitubercular medication. So we rely on more simple criteria for diagnosis of ocular TB. They include first, compatible clinical findings, for example, anterior granulomatous uveitis, as the patient we showed, positive immunological test, which could be a tuberculin test or quantiferon, therapeutic test, which is a response to a 4-week course of antitubercular medication, and of course, exclusion of other causes of uveitis. I think this criteria are much simple and more practical to apply at least to our group of patients. I will show some of the cases that that's compatible with the codes and the other case which we put our criteria and the diagnosis. This is a 32 female patient that came with anterior granulomatous uveitis. Workup was negative for almost everything, except the quantiferon test was positive, and tuberculin scan test also was positive, and CT chest showed this typical Ghon's focus with apical fibrosis. So by applying the COTS criteria, we are justified to start antitubercular medication in this patient. This patient had anterior granulomatous uveitis and a positive CT chest. So according to the COTS, we can initiate antitubercular medication. The second patient is a 42-year-old female patient that complained of blurring of vision and the floaters in both eyes for 2 years. She was given topical steroids with no response. Anterior segment inflammation showed mild uveitis in both eyes. Posterior segment showed vitritis in both eyes, in addition to this massive bilateral cystoid macular edema. Laboratory workup was ordered and it revealed normal CBC, ACE, ESR was elevated, MRI of the brain was normal, urinalysis was normal, but the tuberculin skin test was strongly positive with 31.5 millimeter of induration. So this is a very strong tuberculin skin test. But the chest X-ray was unremarkable. In the chest X-ray, we look for bilateral hilar lymphadenopathy, but the chest X-ray, here we look for the typical chest X-ray finding like Ghon's focus or apical fibrosis. So our impression was anterior and intermediate uveitis, strongly positive BBD and cystoid macular edema, and we diagnosed her as having ocular TB. If we apply the COTS criteria, here we are not justified to start treatment because the patient had negative chest X-ray. But we elected to start her on treatment, and this was after 40 days of antitubercular medications alone without use of systemic steroids, and this was after 75 days, and the macular edema almost completely subsided in both eyes, and we consider this as a positive therapeutic test. The third case is a 35 male patient complained of blurring of vision in the left eye for 6 months. He used systemic prednisone and other and was not responsive. Of course, when we have patients like this not responding to immunomodulatory therapy, we think of infection and masquerades like the case presented by Dr. Sherein. And this was the fundus examination of the patient, showed multifocal choroiditis. We did labs for him, and the BBT was strongly positive. As you can see here, it showed this massive scar, and the chest X-ray was normal. So again, if we are coming to the COTS criteria here in the middle part, multifocal choroiditis, you must have chest X-ray or CT chest to treat this patient. But in fact, we applied our criteria and we treated this patient, and the results were fine. The next patient is a 59-year-old male patient, complained of pain and redness in both eyes of 2 years duration. He was given extensive topical steroids, and anterior segment inflammation examination showed nodular scleritis and the peripheral corneal infiltrates, as you can see here. He has severe scleritis and peripheral corneal infiltrates in both eyes. Lab tests were almost normal except for quantiferon test was positive, and the CT chest was normal with no evidence of TB. This, as here, the CT features are normal. And this is after treatment with anti-tubercular medications alone without systemic steroids. You can see the results here. The picture on the left before treatment, the picture on the right after treatment. And we had published our experience in the British Journal of Ophthalmology a few years ago about the tubercular itis and the treatment with anti-tubercular medications alone. Lastly, we have, alhamdulillah, published our paper with my colleague, Dr. Hind Amin, about the presumed ocular TB in Egypt. The research question that we tried to address, Dr. Hind Amin and I, was this issue. Should we stick to the COTS criteria with having positive imaging, either CT chest or chest X-ray, in order to start anti-tubercular medication? And alhamdulillah, thankfully, we succeeded to convince the editors that it is not a must. And our cases here in Egypt were mostly anterior and intermediate uveitis, and most of the cases had no concomitant active or healed pulmonary TB, and this was published 2 months ago in the Ocular Immunology and Inflammation Journal. So, in conclusion, diagnosis of ocular TB is challenging. For me, I am a part of the COTS, and I encourage everyone to stick to the COTS criteria because it is a landmark in uveitis. But keep in mind that we are clinicians and you have to use your clinical judgment. So if you apply COTS and you still think or believe that the underlying etiology is ocular TB and you successfully excluded other causes of uveitis, so don't hesitate to start anti-tubercular medication and keep an eye on your patient to check the diagnosis and to interfere properly. And this is the list of our publications on TB. Thank you very much.
تسلم ايدك يا دكتور سمير، حاجة طبعا جميلة جدا. Very nice presentation indeed. طبعا في أسئلة كتيرة بالذات التيوبركلوزس، يعني فيها controversies كتير جدا.
تحت
طبعا
أمرك.
الحالات اللي بيبقى فيها البروتوتايب اوف تيوبركلوز زي جرانيولوماتيس كيبيز، زي نودولار infiltrate او multifocal choroiditis with the typical appearance او serpiginous like choroiditis. كل الحاجات ديت بتخلينا لو في تي بي بوزيتيف حتى without any other يعني pulmonary manifestations بنجو ahead طبعا ونقول غالبا ده تي بي. بس السؤال هو في الحالات اللي ما فيش فيها البروتوتايب، يعني في حالات كتيرة بتبقى just vitritis أو just anterior uveitis with no obvious granulomatous uveitis. we TB positive, we cannot find any
حقيقة
other
دكتور محمد، هي
cause of.
فعلا
سامعني يا دكتور سمير؟
تمام دكتور محمد، هي فعلا بي انا سامع حضرتك. طبعا هو حضرتك السؤال ده مهم جدا، وفعلا هو ده بيقابلنا في معظم الحالات زي ما حضرتك بتقول كده، وبيبقى حاجه فيري كونفيوزنج. يعني بص، على سبيل المثال حضرتك الاسبوع اللي فات كان عندي احد المرضى وكان عنده يونيلاترال anterior uveitis with hypopyon. عملت له كل اللاب ورك اب ومن ضمنهم الكوانتيفيرون تيست طلع فيري هاي، strongly positive quantiferon test. بس الحقيقه انا لقيت ان ده مش كومباتبل مع شكل اليوفيايتس، يعني هو يونيلاترال وهايبوبيون، والتي بي ريرلي بيبريزنت كده. فانا الحقيقه فضلت ان انا ما اعالجوش على ان هو تي بي، وطلبت له سي تي تشيست بس بندنج. عملت له تشيست اكس راي كانت نيجاتيف، فقلت خلينا نشوف سي تي وذ كونتراست، ولسه مستني النتيجه. فهو إجابة سؤال حضرتك، أنا بعمل زي ما حضرتك بتعمل كده، بحاول قدر الإمكان اكسكلود الأذر important causes الأول. لكن لو هو الكلينيكال بيكتشر مش متسقة مع التي بي، الإيج مش متسق، السوشيو ايكونوميك ستيتس، كل ده طبعا اي كونسيدر ات. طبعا في مشاكل في بدايه علاج التي بي، لان هو مش افيلبل. الصعوبات اللي بنقابلها طبعا مع البلمونولوجيست ان هم يبتدوا العلاج، فلازم احنا يبقى عندنا درجه عاليه من اليقين انه ده تي بي علشان البيشنت تستارت تريتمنت. كمان مشكله الريزيستنس، دكتور محمد، هم برضو زملائنا في الصدرية بيهزيتيت، لأن هم بيخافوا ما يكونش تي بي، فمش عايزين يدوا أدوية علشان الريزيستنس والإيشوز دي. فإجابتي لحضرتك إن إحنا لازم to make every effort to rule out other causes، ونبقى حاطين عمر العيان في ذهننا والكلينيكال برزنتيشن.
السؤال التاني معلش يا دكتور سمير، حضرتك
اتفضل يا
ستريسد
فندم.
على ان السكين تيست is strongly positive وان الاجرا is strongly او الكوانتيفيرون is highly positive. في كذا study try to associate الليفل بتاع السكين ريسبونس او الاجرا ريسبونس with ان ده يكون تي بي فعلا. and يعني كان الريزلتس بتاعتهم كلها controversial. فهل should we depend على لو هو الاريا بتاعت التي بي تيست مثلا سكين تيست انها مثلا 25 ملي او 30 ملي this is highly suggestive ان ده يكون تي بي، ولا just it means ان في latent تي بي and that's all.
تمام، والله سؤال جميل يا دكتور محمد. زي ما حضرتك قلت كده، هو في كونتروفيرسيز، وانا من قراءاتنا ومن المناقشه مع دكاتره الصدريه، احيانا الارقام في الكوانتيفيرون ما بتفرقش معاهم. يعني هو مثلا معظم اللابس بتطلع 0.35، اللي اكتر من كده يبقى بوزيتيف. البيشنت اللي كلمت حضرتك عنه الاسبوع اللي فات طلع 9، يعني حاجه عاليه جدا. بالنسبه للتيوبر كلين سكين تيست، هو المفروض يونيفرسلي لو اكتر من 15 ملم اوف انديوريشن. وده بياخدنا النقطه تانية، ان هو لازم اللي بينتربريت التيست يكون سكيلد وعارف هو بيعمل ايه. I used to do this test by myself before، ان احنا لازم نلاقي اند ديوريشن مش اريثيما، ويكون 15 ملم او اكتر. طبعا في حالات لو هو 15 ملم او اكتر ده بوزيتيف في اي حاله من الاحوال. لكن لو في حد مثلا اميونو كومبرومايزد زي الاتش اي في بيشنتس، ممكن يبقى اقل من كده 10 مثلا او 5. والناس اللي هم الهيلث بيرسونيل، الارقام اللي اقل من كده بتبقى مهمه فيهم. طيب لما يطلع حضرتك ال زي الصوره اللي انا عرضتها، في 31 ملم، وعنده في كمان اولموست سكار، فمعنى كده ان في رياكشن عالي. فده يديني كلو ان هو ممكن يكون البكتيريولوجيكال لود عنده عالي، والهايبر سنسيتيفيتي رياكشن عنده قوي جدا نتيجة الانتيجينيك لود اللي عنده. فده بيخليني ابقى اكتر انكلايند ان هو ده تي بي. لكن scientifically speaking وكبيبرز وكريسيرش مفيش حاجة بتؤيد ده. لكن زي ما حضرتك عارف طبعا، في كل حالات اليوفيايتس زي الفي كي اتش والساركويدوزس والتي بي، كلها بتعتمد على كلينيكال كرايتيريا، مفيش دايجنوستيك تيست واحد. حتى البهشتس ديزيز وكل الحاجات دي كلها دايجنوستيك كرايتيريا. فاحنا بناخد ده in context مع بقية ال findings to try to reach the most likely أو most probable underlying etiology.
طيب انا هسيب
دكتور
الناس بقى
سمير،
تسأل، متهيألي في ناس كتير عاوزة تسأل.
أنا عندي سؤال.
اتفضل.
حضرتك بتتعامل إزاي مع patients اللي حضرتك لسه بتقول عليه الأسبوع اللي فات؟ هو clinical picture بتاعته ما تقولش إن هو ده تبي، رغم إن إحنا عارفين إن هو the great mimicker وإن هو ممكن يجي بأي شكل، بس أوقات بتبقى الصورة حطانا في entity تانية. وتقدر تقول ان هو هيبقى التشخيص ده الدايجنوزس الانتيتي التانية، لولا ان طلع لك الكوانتيفيرون بوزيتيف او التيوبركلين هايلي بوزيتيف وهايلي سجستيف. فبتكونسيدرت بقى ان هو عنده الاذر انتيتي، بس هو البيشنت ده كمان تيوبركلس، فبتديله بروفيلاكتيك انتي تيوبركلس تريتمنت، ولا بتتصرف ازاي في العين ده؟
تمام، سؤال جميل جدا يا دكتورة مي، وبنقابل السيناريو ده في بعض الأحيان. لازم يبقى عندنا برضو شوية معلومات كده. الليتنت تي بي موجود في 30% من سكان العالم وورلد وايد. كإحصائيات عالمية. طبعا بيفرق من مكان للتاني، لكن احنا بنفترض ان انا لو عملت الكوانتيفيرون ل 100 واحد كده، هيطلع عندهم 30 منهم هيطلع عندهم الليتنت بي. عشان كده ده احد الاسباب اللي بيخلي برضو زملائنا دكاترة الصيدلية ما يرضوش يعالجوا. بيقول لك انت، انا لو عملت التست ده لاي حد ممكن يطلع عنده ليتنت بي ومش هو السبب. طيب انا بالنسبة لي في الحالة دي بعمل ايه؟ براقب العيان بشكل كويس جدا. يعني انا حاطط ريد فلاج ان ده عنده ليتنت بي او كوانتيفيرون بوزيتيف. انا بعمل كوانتيفيرون لحاجتين، للتشخيص وللعلاج. بعد كده حتى لو هو التي بي مش السبب، المريض ده لو طلع بكوانتيفيرون بوزيتيف مش هقدر اديله بيولوجيك ثيرابي. ممكن الراجل ده يطلع بي 27 ريليتد، ممكن يطلع اميون ميديتد ديزيز، وافكر له في مرحله من المراحل ان انا اديله بيولوجي. فانا كده اي كانسل ذس. ما بنديش بروفيلاكتيك تريتمنت لو انا مش ما عنديش حس ان ده ان ده تي بي. فانا بعمل ايه؟ يعني لو البيشنت اللي زي ده، انا السيناريو ان انا طلبت له السي تي، لو طلع نيجاتيف انا هتعامل معاه على ان هو ميديت اميون ميديتد. انا عملت له اكستنسيف ورك اب، انا فيري جينيرس في الورك اب بتاعي، واعتقد كل اليوفياتس سبيشالست بالطريقه دي عشان نقدر نوصل للتشخيص. ويوفيايتس always is like a movie، يعني عاملة زي الفيلم كده، لازم أبقى متوقع التغيرات. بتبتدي بحدث وممكن في النص يحصل حدث وفي الآخر تلاقي النهاية مختلفة خالص زي ما حضرتك قلت كده. فالحل في ده إن أنا أراقب العيان رقابة لصيقة. عندي يونيلاترال يوفيايتس مع هايبوبيون، فبعالجه توبيكالي، براقبه، بشوف بعد ما اوقف التوبيكال تريتمنت هل بيرجع تاني، هل البيهيفير اتغير، هل الكي بيز دي بقت جرانيولوماتس في مرحله من المراحل. ساعتها لازم اكونسيدر بقى البوزيتيف كوانتيفيرون اللي حصل. لكن لو فضلت يونيلاترال ومفيش ايفيدنس اوف جرانيولوما، البوستيريور سيجمنت از فاين، مفيش فاسكولايتس، مفيش الحاجات اللي زي ما دكتور محمد قال اللي هي الفينوتايبس بتاعت التي بي، انا مش هحطه في دماغي. فهو اجابه سؤال حضرتك في الحالات دي هي المراقبه اللصيقه، على اساس ان انا اشوف لو في حاجه حصلت في العين او في الجسم تخليني اغير خطه العلاج يعني.
في دكتورة ضحى جهاد كانت سألت سؤال كويس الحقيقة. بتسأل يعني هل الجماعة بتوع البالمونرست يعني هل بيبتدوا ب 2 agents ولا 4 agents هنا في مصر؟ وايه الريكومندد بيريد؟ يعني هل هي 6 months ولا 9 months ولا how do you extend the period؟ وهل انت بتبتدي ستيرويدز من الاول ولا depending on the phenotype او هل هي انت يعني متوقع انها تكون intra ocular mycobacterium ولا ده immunological reaction accordingly you start steroids ولا بتبتدي في كل حالات steroids؟
طيب سؤال فعلا جميل جدا يا دكتور محمد. هو في شقين مهمين قوي. الشق الاولاني الديوريشن اوف تريتمنت. احنا بندي 6 شهور اتليست، وده اقل حاجه للتريتمنت اوف تي بي ان جنرال. بس هو في تريك هنا مهمه قوي. لازم كل حد من حضراتكم ومننا يبقى عنده بالمونولوجيست، يبقى هو مفهمه كويس قوي ايه الموضوع الاوكيولار تي بي ويقنعه. لانه للاسف طبعا او مش للاسف، هو ده الوضع يعني المنطقي او المتبع، انه ده علاج الضرر موجود بس في الاماكن الحكوميه، وما بيتصرفش غير بروشته دكتور صدريه. فلازم دكتور الصدريه هو اللي بيكتب العلاج، ولازم بناء عليه هو يقتنع بتشخيص حضرتك. عشان يقتنع لازم يشعر ان احنا فاهمين. يعني انا شخصيا لما ببعت لدكتور الصدريه ببعت له التشخيص بالظبط الاناتوميكال. والله بقول له العيان ده عنده anterior granulomatous uveitis in both eyes. We excluded all other causes of uveitis, and the most likely diagnosis is ocular TB. And I want to start him on anti-tubercular medication for drug regimen for 6 months. فإجابة سؤال حضرتك، بيتعاطي 4 أدوية مش دوايين، 4 أدوية مش بروفيلاكتيك، هو علاج بيتاخد فور ميديكيشنز اللي ستاندرد تريتمنت فور 6 to 9 months. احنا بالنسبه لنا الحقيقه في الاوكيولار تي بي بندي 6 months بس. يعني احيانا بيبقى 9 شهور مثلا او سنه لو هو عنده كو اكزيستنت بالمونري تي بي، وده بيكون بتحديد من دكتور الصدريه. لكن احنا بالنسبه لنا في ممارستنا احنا في الاوفثالمولوجي، لو هو بيور اوكيولار تي بي بندي 4 دراج ريجيمن، مش بروفيلاكتيك 2 دراجز. ده اجابه السؤال الاولاني، اللي هو بندي 4 دراجز لمدة 6 شهور، وبتزيد حسب حسب الحالة لو هو معاه حاجة تاني جسمانية. يعني في حالة من الحالات شفتها كانت ميلياري تي بي، ودي خدت فيري برولونج تريتمنت مع البلمونولوجيست، واحنا اللي اكتشفناها. يعني هي ما كانتش معروفة، واكتشفنا ان هي عندها اوكيولر تي بي، ولما راحت لدكتور الصدرية وعمل لها الورك اب طلع عندها ميلياري تي بي. فدي طبعا حاجة مهمة جدا، يعني برضو ان احنا to save the life of the patient. بالنسبة للسؤال التاني، هو سؤال جميل جدا، لانه برضو في controversies. احنا زي ما قلنا برضو في البرزنتيشن، التي بي ممكن يكون نتيجه الاكتيف ريبليكيشن اوف ذا اورجانيزم، وده بيبقى محتاج انتي تيوبركلر ميديكيشن، او يكون نتيجه الهايبر سنسيتيفيتي رياكشن، وده محتاج ستيرويدز. والحمد لله الدكتوره هند امين ادرست النقطه دي جدا في البيبر بتاعتنا اللي احنا نشرناه. انا شخصيا بعمل ايه لو انا جالي عيان وانا شخصته اوكيولر تي بي؟ بديله انتي تيوبركلر ميديكيشن الون فور 2 ويكس. ليه؟ علشان اثبت التشخيص لنفسي. انا عايز اثبت ان هو تي بي. في معظم الحالات ما بيحتاجش ستيرويدز تاني، وبيرسبوند دراماتيكالي الحقيقه، لدرجه ان انا شكيت انه الانتي تيوبركلر ميديكيشنز دي لها انتي انفلاماتوري افكت. والحاله اللي انا عرضتها من ضمن الحالات عرضتها لحضراتكم، كان عندها سيفير فيترايتس وماكيولار ايديما، شي ريسبوندد دراماتيكالي للانتي تيوبركلر ميديكيشنز الون، والفيترايتس سبسايدد والماكيولار ايديما. طيب نفترض ان انا بعد اسبوعين I'm pretty sure من الدايجنوز، بس بعد اسبوعين لقيت الانفلاميشن لسه موجود وفي فيترايتس. ساعتها في سيناريوهين. السيناريو الاول ان ده ممكن يكون يا شيركزايمر رياكشن نتيجه الكيلينج اوف ذا اورجانيزم، وان انا حررت الانتيجينز وحركت الجهاز المناعي، ساعتها انا محتاج ادي ستيرويدز. يا اما يكون الباثولوجي نفسه، يكون سبب الانفلاميشن مش الاكتيف اورجانيزم. وانا اتذكر مقوله يعني الاستاذ الدكتور خالد طباره اللي علمني انه ممكن اورجانيزم واحد، مايكوبكتيريا واحد بس في الكرويد، يحرك كل الالتهابات دي. فاحنا مش محتاجين بقى ندي الهيفي انتي تيوبركولار ميديكيشن. تمام. فانا بدي الانتي تيوبركولار ميديكيشن فور 2 ويكس من غير اي ستيرويدز خالص، وبعد اسبوعين بعيد تقييم الامور. لو احتجت ادي اورال ستيرويدز بدي اورال ستيرويدز مش اكتر من 40 مللي جرامز. والحقيقه عندنا جروبس، يعني حتى ده في البيبر احنا كاتبينه بالتفصيل مع الدكتوره هند. في جروب خدت انتي تيوبركلر ميديكيشنز لوحدها، في جروب خدت انتي تيوبركلر ميديكيشن وستيرويدز بعد اسبوعين، وفي جروب خدت ستيرويدز بس. فهو طبعا it is an art حسب الحاله اللي هي قدام حضرتك يعني ان شاء الله.
وآخر سؤال معلش يا دكتور سمير، دكتور أحمد بيسألك إيه الرول أوف سامبلينج من الإيكوس ومن الفيتريس وبي سي آر and so on in diagnosing TB.
تمام، هو سؤال جميل برضو. احنا يعني we addressed it in the talk. هي ده طبعا ده diagnostic. لو احنا عملنا ده وطلعنا الميكوبكتيريم باسيلاي من الايكوس او من الفيتريس، ده فيري امبورتنت. لكن هي المشكله زي ما قلنا ان ده بوسي باسيلياري ديزيز، يعني ممكن ما تلاقي الفيري سكانتي اورجانيزم، فممكن جدا السامبل اللي احنا واخدينها ما يكونش فيها الاورجانيزم. تاني حاجه زي ما احنا قلنا انه لو انا عندي مثلا اللي هو فيه كرويدايتس، مش هقدر اخد سامبل من الكرويد، يعني مش هقدر اخد سامبل من الريتنا. وطبعا بالاضافه انه الاوكيولار سامبل دايما بتبقى سكانتي ومش كافيه للباثولوجيست. علشان كده كل المجهود العلمي العالمي اللي معمول ده علشان ما فيش بايوبسي. يعني الكوتس ستادي دي دراسه كبيره جدا وفيها 5 بابليكيشنز الحقيقه، وكل ده اتعمل عشان يلاقوا كونسنسس، لانه ما فيش مش سهل ابدا ان احنا تو اوبتين بايوبسي اور ايكوال سامبل يعني. فهي الحقيقه براكتيكالي لها فيري ليميتد رول.
وبرضه البي سي ار يا دكتور سمير ملوش
اه
رول
لازم
قوي الصراحة.
بالظبط كده. ملوش بس ده حقيقي، ده حقيقي يا دكتور محمد. انا بقول لحضرتك انت بعد حتى ما تعمل بي سي ار ومالتيبل امبليفيكيشنز والكلام ده كله ممكن ما تلاقيش الاورجانيزم. فهيبقى برضو مش براكتيكال ان احنا بنستخدمه يعني. بنعتمد على الدايجنوستيك كرايتيريا اكتر يعني.
I think we need to move to دكتورة تريز يعني مسك الختام. دكتورة تريز هتتكلم لنا على المالتي موديل دايجنوزز في اليوفيايتس.
مساء الخير جميعا. انا هحاول ما اطولش عليكم. هي كده البرزنتيشن بتاعتي باينه.
واضحة.
اه يا
دكتورة
دكتور
تريز is
واضح.
a uveitis consultant في الوطني اي هوسبيتال.
ثانيه واحده.
واضحة يا دكتورة
آه،
تريز.
اوكي. أنا هبتدي بحالتين، حالة على الشمال وحالة على اليمين. الاتنين طبعا الفرق بينهم كبير جدا، واحدة very aggressive واحدة very minimal changes. هما حالتين كورويدايتس، وهدف الصورة دي هي إن احنا نتفق إنه choroiditis is a very very wide spectrum. In literature, for simplicity and clinical application, it has been divided into choriocapillaritis and stromal choroiditis, and the term white dot syndrome is less commonly used. The type of choroiditis would depend on the level that's affecting. يعني لو large choroidal vessels في الاستروما بتاعت الكرويد بنسميها stromal choroiditis، ولو هي ال small choroidal vessels اللي هم more anterior بتبقى choriocapillaritis. The prognosis of the disease would depend on the extent of involvement of the choroid and the reversibility of the changes that have occurred. ناخد أول سب انتيتي اللي هي كوريوكابيلارايتس. في نوعين، في البرايمري والسكندري. البرايمري تايب it's called primary inflammatory choriocapillopathies sorry. they includes الحاجات اللي احنا طول عمرنا عارفينها، والابريفيشنز اللي هي ميوت وامبي وبيكس وايديوباتيك مالتيفوكال وازور. اما السكندري فهم نوعين infectious، وهم actually phenotypes of two very common infectious entities in the uveitis clinic, which is the acute syphilitic posterior placoid وال TB related serpiginous choroiditis. أنا هبتدي بالبرايمري choriocapillaриtis. It can, as I mentioned earlier, just show very subtle changes. ودي عيانة 35-year-old female patient complaining of a relative central scotoma. اما عملنا الاو سي تي المالتي كولر ايميجينج باينه شويه جرانيولاريتي، بس في البوستيريور بول الاو سي تي سكانز مبينه disrupted outer layers في الفوفيا وفي البارافوفيال ارياز. اما نبص على تحديدا البلو اوتو فلوريسنس we can see that the patient has hyper autofluorescence in the hyper autofluorescent dots في ال posterior pole parafoveally وكمان في ال peripapillary area. ودي طبعا is a case of mute or multiple effervescent white dot syndrome. دي صورة تانية of a more severe or more typical case. It has this typical rat-like appearance that are more prominently seen in the peripapillary area and in the macular area. وما نبص على wide field imaging we can see that these lesions spread and extend to the mid periphery. Looking at the OCT, it shows very, very characteristic findings. It shows this disrupted outer layers, thickened RPE. We have this hyperreflective lesions that spread vertically into the inner layers and sometimes may even get to the outer nuclear and outer plexiform layer. فما نشوف الشكل ده we have to think about mutes. Mute is known to be a self-limiting condition. It's known as the flu of the retina. بس أحيانا it can be accompanied with periphlebitis as in this case, and actually it has been reported in literature. وما نشوف حالة زي كده we have to think of an associated systemic disease. وactually العيان ده كان عنده sarcoidosis. الانفاس imaging is one of the very interesting tools that helps you see the patient when he's active, and we can see gradually when you have this slabs over the outer retinal layer how the layers regenerate both in the in-fast imaging and also in the OCT scans. Interestingly, choriocapillaris was found to show no defect in flow. You can see that this all during the baseline, which is the active stage, up to 8 weeks, when the patient had completely resolved, there was no areas of hyporeflectivity within the choriocapillaris or flow void, meaning that actually the choriocapillaris seems not to be affected much in this disease. وعشان نفهم ده لازم نفهم الباثوفيسيولوجي بتاع الموضوع ده. اللي بيحصل انه الchoriocapillaris there are end capillaries within the choriocapillaris, and these are actually thought to be mostly affected في mutes. Involvement is very minimal and it is mainly reflected as involvement of the photoreceptors. فبنلاقي RPE disruption و increased phagocytosis of the photoreceptors و increased lipofuscin accumulation. ودي الحاجات اللي احنا actually بنشوفها في ال OCT scans وبنقدر نشوفها في ال autofluorescence. When you have a case of mutes and you're following up this patient by the wide field imaging, you would think the patient is improving and resolving. بس لو جينا بصينا هنلاقي supratemporally العيان ده عنده small العيانة دي عندها small punched out lesion hypo autofluorescence. ولو بصينا further هنلاقي العيانة دي عندها several other lesions that were not seen at baseline. وده التين لاين بين العيانين اللي عندهم ميوتس وبانكتيت انر كورويدوبتي. Occasionally, though mute is known to be self-limiting, it can actually be the initial presentation of punctate inner choroidopathy, which is a more disease with a more aggressive and more protracted course that needs more intense treatment than mute. دي الابتوس images بتاعت نفس العينة. we can see clearly how these lesions have developed. والعينة دي actually was started on steroids and immunosuppressants and she was doing very well لغاية لما في يوم جت قالت لي إن she has developed an inferior visual field defect. والعينة دي actually she was very intellectual ف I had to take her complaint seriously. وما عملت لها الابتوس imaging I could see that there was some active lesions in the periphery بس it doesn't explain اللي هي بتقوله. So I had the same images taken again, but using the blue autofluorescence that best shows the lipofuscin accumulation. ولقيت إن هي فعلا عندها a large patch superiorly of hyper autofluorescence denoting damage of the photoreceptors or acute photoreceptoritis on top of pics. And this was a condition that was described where you have acute photoreceptor loss in patients with pics that would show changes that are not proportional to the complaint of the patient. I move on to the more aggressive entity of primary choricapillaritis, and this is a patient. She is a middle-aged myopic female patient, and she developed punctate inner choroidopathy, and we can see this is the typical appearance. You have this hyper autofluorescent areas in the posterior pole, and you have the PIC lesions. And when you have a hypo autofluorescent PIC lesion, like the temporal one, and it has a rim of hyper autofluorescence, then you know that this is an active lesion and this patient will have this lesion increasing in size and you have to treat this patient more intensely. The images of the OCT in this patient is very interesting, and this is the same patient in the acute stage. Cutting through this punctate lesions, you can actually see a large nodular lesion that is extending through the outer layers, through the Brooks membrane, and going into the inner layers. And also part of this nodule is seen in the choriocapillaris, and you have the characteristic trail area hyperreflective line, which is increased choroidal transmission. That mainly denotes activity, and you have a few other lesions centrally. And there are several stages of PICS that you can see by OCT that would help you know that the patient is improving. Some of these lesions, as you can see under the yellow arrow, start to decrease in size with treatment, then they completely resolve and the outer layers sometimes reconstruct. Or if the lesions are large, sometimes they can leave an excavated area اللي هو healed PIC lesions اللي احنا بنشوفها clinically. You can see a complete area of ischemia within the choriocapillaris. The autofluorescent images using the white field in these patients actually helps you see the number of lesions, if the lesions are increasing in size, if you have the lesions, if you have some active lesions that you have to consider and keep watching, or you have to escalate your treatment to control the condition. In punctate inner choroidopathy, one of the very important entities you have to watch out for is the development of CNV, and this is one of my patients. She looked quite decent and was doing very well on treatment until she came with decrease in vision, and we can see by OCT angio and OCT scans she had developed a typical inflammatory CNV cutting through, developing through the PIC lesion with the typical pitchfork sign. And when you have a patient with PICS who has developed a CNV, you know that you have to not only inject anti-VEGF, but also, excuse me, you have to start increasing the systemic treatment because this means the patient is not well controlled. This is a patient, a 27-year-old male patient who came with bilateral decreased vision in both eyes, and clinically he had these creamy lesions that were coalesced together involving all the posterior pole, and actually you can see the hyper autofluorescent appearance correlating with what we could see in the multicolor imaging. The OCT scans showed this very characteristic hyper-reflective accumulations in the inner layers and disruption of the outer layers, and the choriocapillaris actually looks involved. And this is the fellow eye, but having a more aggressive appearance. And this is typically what acute posterior multifocal placoid pigmentary epitheliopathy, or MP, which is also another type of primary choriocapillaritis. And for us to understand how to deal with this case, we have to understand the pathophysiology of this condition. What happens is that when activation of sensitized lymphocyte and cytokine diffusion occurs secondary to either infection or vaccines, what we have is that there is very low perfusion pressure within the choriocapillaris. This is the nature of the circulation within the choriocapillaris. When this happens, the terminal arterioles occlude very easily, and the normal intraocular pressure of the eye causes occlusion of the draining venules. So what happens is that you have swelling that occurs within the lobules of the choriocapillaris, and this would induce what we had seen. It induces disruption of the RPE function, accumulation of these inflammatory aggregates that are either actual inflammatory changes or secondary to ischemia, and also ischemia within the choriocapillaris. For us to appreciate the extent of ischemia that occurs in MP, we have to look at the OCT images of this patient. At baseline, you can see that the patient almost has no perfusion within the posterior pole, and gradually and with treatment, the patient starts to have some restructuring of the vasculature of the choriocapillaris in both eyes. But even at the end, the patient still shows some areas of ischemia. This is completely different from the OCT angio we had seen in mutes. And this explains that when you have patients with different types of primary choriocapillaritis, what causes the visual damage and the prognosis is the extent of ischemia that occurs in the choriocapillaris. This was after the patient received treatment opposed to onset, and these are the OCT images of this patient. The right eye had some foveal photoreceptors preserved, and so he had better vision in this eye compared to the other eye. The patient had some scarring that remained, and which is common in MP. MP is not usually an isolated disease. You have to keep in mind that it can have serious systemic associations that include cerebral vasculitis, cavernous sinus thrombosis, even meningoencephalitis that may need neuroimaging depending on the patient's complaints. TIA, scissors, transient hearing loss is not uncommon, and I have a few patients like this, or even sixth nerve palsy. I will move on quickly to secondary choriocapillaritis, and as I mentioned, there are two infectious entities. The most common is serpiginous TB. So when you have this multiple lesions, yellowish creamy lesions scattered in the posterior pole and mid-periphery sporadically, you have to think about TB, even if it is bilateral. A very important tool that you can use to image these patients is the ultra-wide field imaging, and this is the ultra-wide field imaging of the same patient I had just shown you. And you can see the extent of the hyper-autofluorescent serpiginous lesions. These are the active lesions. When you have these hyper-autofluorescent lesions, these are the active lesions, and you can see how this hyper-autofluorescence has almost completely resolved when the patient had received treatment. And this is the fellow eye. You can see the active lesions if you concentrate on the posterior pole, and you can see how these lesions actually eventually resolved. So as Dr. Samir had mentioned, TB is a very difficult disease to diagnose. And one of the reasons is that what we see in serpiginous is it's a hypersensitivity reaction to TB bacilli that are actually present in the RPE. The site of the TB bacilli is in the RPE, and this is why it's very difficult for us to get to it by tissue sampling or aqueous fluid sampling. This causes inflammation that affects the choriocapillaris and the inner choroid and the RPE. And as you can see, it's affecting a larger area of the choriocapillaris than I had mentioned in the other disease entities. And this causes actual permanent ischemia of the choriocapillaris. This is another patient of my cases. And the reason why I put this up is to emphasize what we can see by other imaging modalities. This is enhanced depth imaging of the serpiginous lesions. Sometimes you would see this hyperreflective material opening, and sometimes you will see disrupted outer layers and heaping of the RPE. And when you use the OCTA, it's a very interesting tool because it might even show you the extent of the serpiginous lesions. And by the way, the extent of the serpiginous lesion is what I use to monitor the progression of the disease and response to treatment. So at baseline, if you look at the in-fast imaging, you would think that the lesions ended up outside the yellow circle. And this even shows by autofluorescence. But when you look at the OCTA, you can actually see the extent of ischemia that has occurred in the macula of this patient. When the patient starts to heal, the lesions become more homogeneously hypoautofluorescence, as I mentioned earlier. Sometimes the outer layers reconstruct, but actually the choriocapillaris usually remains ischemic and the underlying choroidal vessels dilate. And this is what we see in the OCTA. There is some revasculature of the choriocapillaris. This is the second entity of the secondary choricapillaritis, and this is a patient who is 47 years old. He comes with decreased vision in both eyes and field effect. If we look at the posterior pole of this multicolor imaging in the right eye, you can see this yellowish, well-defined placoid lesion and another lesion nasally, while the fellow eye shows a superior supratemporal lesion. The autofluorescence highlights this very interesting placoid lesions, and this is the condition known as syphilitic outer retinopathy. So whenever we see these images, we have to think about syphilis, and we have to order both the trypanomal and non-trypanomal tests for syphilis. When you look at the active lesions, we can see that there's disruption of the outer layer over the placoid lesions, and sometimes you might find small complexes in the subretinal area. This is after the patient received treatment for TB, opposed to onset, and the fellow eye opposed to onset. Usually, there is complete reconstruction of the outer layers. The underlying mechanism of SOR is secondary autoimmune reaction triggered by antibodies against Trypanosoma pallidum or focal choroidal thrombosis, which causes secondary photoreceptor disruption or actual active syphilitic infection within the eye. I will move on to the second entity, which is stromal choroiditis, and this is the choroiditis that affects the stromal area of the choroid, and again divided into primary and secondary. The primary include birdshot, VKH, and sympathetic ophthalmia. However, the secondary includes many infectious entities such as sarcoid, TB, and syphilis, and other infectious entities. I would go on to VKH, and of course, all of us have VKH patients on daily basis in our clinics. It is inflammation of all the layers of the choroid, diffuse choroiditis, and it occurs. The primary incident occurs, as I mentioned, at the level of the stroma, affecting the melanocytes, and the thickening occurs due to cellular inflammation made of macrophages, lymphocytes, and epithelioid cells that actually contain melanin. I'm going to discuss how we use OCT to monitor our treatment and attacks or recurrences in these patients. This patient had started at onset with subretinal fluid, and when she came to me, she had already started oral steroids, and she had the resolution of the fluid, and the steroids started where she was receiving treatment. The steroids, she was instructed to taper steroids. But we can see at this point that though the patient doesn't have subretinal fluid, the outer layers are completely disrupted and irregular, and the patient has very severe choroidal thickening. We can hardly see the posterior edge of the choroid. So this patient is still very active. You should not taper steroids at this point. You have to maintain a high dose of oral steroids until the patient starts to show thinning and better restructuring of the choroidal layers, because the patient would directly go into an attack even if the patient had experienced initial improvement of vision. This is when the steroids were increased. Again, we can see the patient has restructuring of the choroid and thinning of the choroid, and the outer layers look a lot better. The patient into treatment again developed another attack, and the patient actually didn't have any vitritis or EC cells, but was feeling that the eye was uncomfortable and heavy. Her vision was good at this point, by the way. And we can see how enhanced depth OCT helped us see that the patient again has developed another attack and again in recurrence. This was an interesting paper I had done with my colleague, Dr. Alaa Fayed. We were studying the choroidal density, flow density in patients with VKH. And we found that when the patients were active, we could see these hyporeflective areas within the choriocapillaris, and this denote ischemia. And we can see them best on the map, the choroidal vascular density map. And these lesions completely resolve when the patient was controlled. And when the patient goes back into recurrence, these lesions sometimes develop again. And so what we found was that the choroidal vascular density percent was lower in active cases than in quiescent cases, reflecting decrease in flow velocity during activity, possibly due to inflammatory cells that infiltrate the choroid, or it could be some form of actual ischemia. When you have a patient with VKH and this patient develops fluid, it doesn't mean that the patient has developed another attack of VKH only, but the patient may also have an associated CNV. And we commonly see that in the peripapillary area, and best shows using OCTA. And again, when you have a patient with VKH and the patient develops a CNV, you have to remember, you have to keep in mind that the patient is not properly controlled, and you have to either change the line of treatment, and definitely you have to increase steroids at this point. Ocular sarcoidosis, another form of secondary stromal choroiditis, and one of the entities that the eye was used was the multiple chorioretinal peripheral lesions. And actually, I just wanted to show you how this looks like. These are multiple small peripheral lesions with fuzzy edges that are seen in the periphery. Of course, this patient would have other forms of, this patient had vitritis, and this patient had disc edema. And this is the autofluorescent appearance. And this is when the patient received treatment, the lesions started to decrease in size and become more well-defined. And lastly, one of the very interesting entities is the TB choroiditis. And this is one of my patients with a huge TB granuloma. And I'm going to use this paper to help you differentiate between TB granulomas and sarcoid granulomas. TB granulomas are usually large, full-thickness, hyperreflective granulomas that are multilobulated. They show overlying disrupted RPE. They show deep infiltrates in subretinal fluid. And one of the very characteristic and important things is that they have intraretinal or subretinal hemorrhage. So you have a tuberculoma that has subretinal or intraretinal hemorrhages. You have to keep TB in mind. And a very interesting characteristic is that they sometimes have vascular changes that can be highlighted by fluorescein angiography. And sometimes they have retinal angiomatous proliferation. And this is why anti-VEGF has a role in treatment of these cases with treatment of anti-TB. Secondary granulomas sarcoid granulomas, on the other hand, are usually multiple and smaller, and they are dull yellow in color. And this is an example. This is very interesting because sometimes if you just see this, you would think this is just a pachychoroid or just a dilated choroidal vessel. Actually, no, this is a sarcoid granuloma. And this is a larger form of sarcoid granuloma with subretinal fluid. And this is my last slide. This is a patient who was referred to me on the thought of having peripapillary choroiditis with exudative detachment. And because this patient looked very suspicious, actually decided to have a PET scan. The patient actually was found to have cancer breast that she wasn't aware of, unfortunately. And this was a choroidal metastasis. Thank you. This is my last slide.
الحقيقة
شكرا جدا يا دكتورة
جميلة
تريز، يعني
جميلة.
very very strong presentation صراحة
Thank
يعني.
you, Dr. Hussein.
والايمجنج تحياتي بجد، يعني الكومبينيشن انك تبقى حد شاطر في اليوفيتس والايمجنج بيعرف يشتغلها حلو بحيث ان هي تساعده، يعني ما شاء الله. تسلمي.
ميرسي، ربنا يخليك يا دكتورة، ميرسي.
مش عارف إذا كان حد هيبقى عنده أسئلة ولا لأ.
أو الناس
انا
نامت.
انا عندي سؤال دكتور محمد. انا عندي سؤال دكتور محمد
اتفضل
بعد اذن حضرتك.
اتفضل يا
اتفضل.
دكتور.
الاول شكرا جزيلا دكتوره تريزا، الحقيقه فعلا حاجه يعني فيري انترستنج. ما شاء الله حضرتك يعني حد عالمي في الايمجينج، وزي ما مي قالت يعني احنا بجد فخورين بوجود حضرتك. انا بحتك بناس في الايمجينج يمكن حضرتك مستواكي اعلى منهم بكتير جدا، وربنا يكرمك الحقيقه، يعني حاجه
ميرسي يا دكتور،
هايله
ربنا
خالص.
يخليك،
لا
ميرسي.
الناس ما قامتش
ربنا
على فكرة، الناس
بجد
منبهرة، يعني في صمت
دي حقيقة
انبهار.
فعلا. لا لا ما شاء الله، لأنه أصلا الموضوع صعب جدا، وموضوع الوايت syndromes مش very common in Egypt، يمكن موجود بره كتير. فال to ability to pick up the signs وتبقى حد specialized قوي في الموضوع ده، ففعلا حاجة صعبة جدا. دكتورة تريز، عندي سؤالين لحضرتك. السؤال
اتفضل.
الأولاني، عندي مريضة بيك بانكتينال كرويدوباثي، وبرضه شي از فيري سمارت انتليجنت، ما اعرفش انا ده له علاقه بالوايت دوت سندرومز ولا لا. لكن على اي حال، حضرتك في الحالات دي لما بتيجي تتابعيهم بتعتمدي على الاوتو فلوريسنس بس في الديتكتنج اكتيفيتي مثلا في البريفري اوف ذا ليجن، ولا بتعمل لهم فلوريسين كل مره؟ ده السؤال الاولاني.
لا يا دكتور، انا بعتمد على الاوتو فلوريسنس جدا، وبعتمد تحديدا على البلو اوتو فلوريسنس. احنا معظم الاجهزه الاوبتوس اللي عندنا ما فيهاش بلو، ما فيهاش بلو
تمام.
ريفلكتنس، فوي كان اكشولي ميس ليجنز مع انه بيدونا very very beautiful white field. بس no, they don't actually show us the hyper autofluorescent that I'm looking for around the active lesions. فانا mainly بعتمد على البلو autofluorescence، وبستعمل stitching images اللي هم البانوراما، اللي هم بركبهم على بعض. وانا take a long time ان انا اقعد ابص على كل كوادرنت واقارن الحته دي الكوادرنت ده بالكوادرنت المره اللي فاتت. I don't use fluorescein at the end. كل الليجنز هيبقوا they will just be staining في الاخر، ومش هقدر، مش هيساعدني قوي
تمام،
الفلورسين.
ممتاز، بيرفكت، طبعا ات ميك سنس. طيب السؤال التاني حضرتك هو برضه بياند ذا سكوب، بما ان حضرتك بتشوفي الحالات دي كتير. آه، حضرتك عندك تفضيل معين لأي ميديكيشن في حالات البيك؟ يعني المريضة اللي بقول لحضرتك عليها دي تعتبر سنجل ايد، شي لوست وان اي، كان عندها almost total scarred retina in one eye، والعين التانية عندها lesions approaching the macula كل شوية، فهي almost single eyed وعندها half field بس، وانا ماشيها على بيولوجيك ثيرابي. في عندك اي حاجه ممكن تنصحي بيها بيست دراج مثلا او ريجيمين معينه؟
ولا يا دكتور، انا لو مكانك هعمل نفس الحاجه بالظبط. يعني I would place the
اه
patient on biologics. Single eyes is a precious eye و very threatened و very unpredictable. ان انا دي امشيها على INTs immunosuppressants عاديه. لا، I would definitely do what you're doing.
تمام، ممتاز. معلش انا اثقلت عليكي، اخر سؤال بقى هو سؤال لوجيستيك كده. احنا حضرتك طبعا الاي سي جي له رول مهم جدا في الكوريو كابيلارايتس اللي حضرتك شرحتيها دي،
طبعا.
وحضرتك طبعا استاذتنا. ايه المانع، ايه المشكله، ايه العوائق ان احنا يبقى عندنا اي سي جي في مصر مثلا؟ هو انا عارف ان هو مش موجود في حتت كتير في العالم يعني، وموجود في مراكز بحثيه بس، لكن ايه اكيد حضرتك فكرتي ان احنا تو امبلمنت الاي سي جي في الاور براكتس، ايه الصعوبات اللي
هو
بتخلينا ما نعملش
المشكلة،
ده؟
يعني احنا فعلا حاولنا نجيبه، بس المشكلة كانت ان لا، يعني هم عرفوا ان هو بيعمل رياكشن جامد قوي للعيانين. في الاول احنا ما كانش عندنا الفلوريسين ماشينز اللي كانت هتصور اي سي جي. then we got the machines اللي هتصور اي سي جي. بس there was a problem with the dye انه ما كانش حد ميال ان هو يجيبها، ما كانوش شور احنا هنستخدمها قد ايه. وكان طبعا الرياكشن، موضوع الرياكشن ده كان very of very high concern. الرياكشن بتاع الاي سي جي اعلى كتير قوي من الرياكشن بتاع الفلوريسين.
ممتاز، ممتاز. هوب ان شاء
طب
الله احنا
سؤال
we
سريع.
can work on this.
سوري. سوري.
اتفضل يا دكتور محمد.
سؤال سريع يا دكتورة تريز. هل
ومن
في رول للفوكال اي ار جي في حالات الوايت دوت سيندروم وفي الفولو اب بتاعهم؟
انا شخصيا مش بعمل كده، بس ممكن في الازور. ده ممكن يبقى يوسفول في الازور تحديدا، لانك انت بتبقى عندك حته delineated و it can progress slowly واحنا مش واخدين بالنا. فممكن قوي في الوايت دوت في الازور، بس في بقيه الوايت دوت سندروم زي البيك وزي الحاجات التانية I already visualize them بحاجات تانية كتير. فمش بحتاج قوي ان انا اعمل المالتي فوكال اير.
I mean it's quantitative، يعني قصدي ان هي for follow up basically. اذا كانت بتتحسن ولا بتقل ولا بتحصل ايه. I
في
think ان في
الازور
كذا بيبر
بنعمله.
بتتكلم على كده يعني.
يعني هو اللي انا عارفاه ان احنا في الازور we can use it، بس في بقيه الحاجات، بقيه الوايد يعني وايد syndrome is a very large spectrum. فيعني في الميوز هو بيبقى باين. انا ببقى شايفه الاو سي تي سكانز، ببقى شايفه الانفاس ايمجز، ببقى شايفه الاوتوفلوريسنس. I can monitor the patient. I'm not worried ان حاجه تبقى حاصله insidious. بس الازور كده، الازور البروجرس بتاعه is very insidious. فعشان كده we use it.
بتشوف الحالات دي
تريس
كتير يا
في
دكتورة
سؤال.
تريز؟
بشوف الوايت دوتس، بس الازور لا، مش بشوف ازور كتير، بس بقيه الحاجات بنشوفها يعني بيجوا طبعا.
تسلم ايدك يا دكتور.
طيب،
ميرسي يا دكتور،
في
ربنا يخليك.
سؤال لحضرتك. آه، في البيك بالذات، how long you treat, and if there is no more hyper autofluorescent lesions you can we stop treatment ولا بتسيبيه as immune mediated يعني؟
هو لو ما عنديش هايبر اوتو فلوريسنت ليجنز فور يير انا ممكن اوقف، بس مش هوقف دايركتلي، يعني مش هبقى، مش اصل هو وانس اللي هو لو بقى اكتف وجاله سبفوفيال سي خلاص هو الفيجن بتاعه مش هيرجع تاني. فهو برغم ان هو يبان سمول ليجنز والدنيا شكلها فيري بناين، بس اكشولي الموضوع it can flare وكوز يعني permanent visual damage، فعشان كده we have to be cautious.
تمام. الحقيقة يعني البرزنتيشنز النهاردة as usual مبهرة. الحقيقة ما شاء الله كلهم كويسين جدا. والنهارده قدرنا نتكلم في كل الانتيتيز، ما كناش كل حاجة بقى، الانفكشوس والنون انفكشوس، وحتى الحاجات اللي احنا صعب ما نشوفهاش كتير، الكوريدايتس. الشهر الجاي ان شاء الله احنا هنرجع تاني اول خميس في الشهر. احنا الشهر ده بس عشان خاطر الاعياد وراس السنة وبتاع فاجلنا شوية، بس هنرجع تاني اول خميس ان شاء الله في فبراير. واتمنى احنا ما نكونش سهرناكم، ما كناش ضيوف تقال يعني.
thank you
تسلم
جدا
ايدك
يا
يا
دكتور.
دكتورة مي.
thank you.
ميرسي جدا.
thank you for your effort.
ميرسي يا مي.
فضلت سهرانة اهو.
فضلت
مواضيع
سهرانة.
حياتنا.
لا I could not resist، يعني I could not resist. لا دكتور سمير ولا تيريز، الحقيقة it was a beautiful presentation. Thank you very much.
Thank you so much.
ميرسي يا
thank
مي.
you so much.
على ايه؟ شكرا للناس اللي تعبت في البرزنتيشنز.
ميرسي ليكي. thank you so much for having us.
ميرسي دكتور سمير، وشكرا، نشوفكم ان شاء الله الشهر الجاي.
شكرا جزيلا
تصبحوا
يا
على
دكتورة
خير
مي.
جميعا.
تصبحوا على خير.
شكرا
باي.
جزيلا دكتور محمد، دكتورة تريز، دكتورة شيرين. الحقيقة أنا شخصيا والله كل مرة بتعلم وبستفيد جدا، ومجهود موفق يا دكتورة مي، ربنا يكرمك يا رب. شكرا جزيلا لحضراتكم
عفوا يا
جميعا.
دكتور سمير، شكرا.
مع السلامة.